Good morning, good afternoon, and good evening, everyone. A very warm welcome to all of you who have joined the meeting today. My name is Andy Lynn, and I'm from the Myanmar Health and Development Consortium. I will be moderating the APMEN's Vivex Working Group annual meeting today with the theme From Pipeline to Policy Towards Optimized Implementation. Please note that these sessions will be recorded and will be made available after the meeting. A few housekeeping rules. Please keep your video on so that we can get maximum engagement, but do keep your audio on mute unless you are speaking during the meeting. I now have the pleasure to introduce Dr. Sadat Das, CEO of Asia Pacific Leaders Malaria Alliance, APMEN. Dr. Sadat joined APMEN from the Harvard T.H. Chan School of Public Health, where he holds appointments as research scientist in the Dean's Office and Department of Health Policy and Management. He is also a Senior Advisor for Research Translation and Global Health Policy at the Harvard Global Health Institute. He's worked in Asia Pacific settings and in West Africa. Please welcome Dr. Sadat.
Thank you very much, Dr. Sandy, and thanks so much to our co-chairs, Dr. Karma and Dr. Lynch, and all of the esteemed speakers who will be participating in the meeting, whom I won't enumerate here, but I'm so grateful to all of them to bring such incredible commitment and brain power and practicality to the work of this working group. And also a small asterisk of thank you to my team for all their hard work in bringing this to fruition. I really don't want to say too much, but I have been thinking about the opportunity that Amita provided to participate in opening this meeting, and I don't want to take up too much time so that you can really dig into the substance of it. But I thought I would just share a few quick points, just verbally, not using slides. Vivex is something that's near and dear in a personal way for me. About 15 years ago, I recall sitting in the highlands of New Guinea with a listless 3-year-old who happened to be my son, wondering what was going on because we didn't have a lot of malaria in the highlands. We lived at the altitude of the US city of Denver in the Eastern Highlands, but had made a recent trip to Port Moresby, and we determined, unfortunately, for me, I have many dear friends and colleagues, including my own partner as a clinician, determined that likely what was happening here was malaria, and we secured an RDT. And while we aren't sure, it was likely Vivex because there was not any response to the treatment that we secured from the provincial hospital in terms of chloroquine. And I think that thinking about these issues, faced with this personally, and of course, being so incredibly fortunate to have the network that I have, to have the colleagues that I did, both Papua New Guineans and other colleagues, and of course, the resources, it still brought to mind that what we were faced with in those moments, in those days, very much echoed what we were doing and the reason why I was there around HIV. So a big part of our program was looking at pediatrics in terms of testing, care, and treatment. A big piece of that included also rolling out DNA PCR for infant testing and figuring out how to build a system for preventing to mother-child transmission. And so why am I talking all about HIV and the highlands of New Guinea? When I think about reviewing what the work in Vivax is constrained by, the issues, remote access and delivery, variable risk of relapse, adherence issues, thinking about adherence versus the need for G6pd testing, feasibility and costs of G6pd testing, supply chain issues, and of course, sustained financing. I'm reminded of so many of the things that we were faced with, and to a lesser degree, those are still challenges, although a system was built to enable the kind of sophisticated diagnostics, supply chain, and mentorship that was required in the case of a complex chronic condition such as HIV. And so when we think about Vivax and we think about how important it is in our region, 9.6 million cases of falciparum versus 12.2, the largest burden of Vivax in the world here in our region with a global cost of $500 million. The work of this group is so important. And this theme that this group is speaking to today in terms of the pipeline to policy to optimized implementation couldn't be more timely, because we know that if we're to meet the 2030 targets, we're going to need not just the novel tools and strategies and the kinds of interventions and incredibly important operational research that goes on, but it will have to be coupled by the commitments to capacity building and interventions that, as we hear time and again, that are tailored to the context, to the socio-cultural and political environments, because there isn't a one-size-fits-all. And we know that. And I think that the critical piece, whether it's HIV, whether it's TB, or whether it's malaria, when we think about these geographies, is that taking those tailored approaches means longer-term commitments, long time horizons, and ones that are public sector driven, which makes the work of this working group and the leadership of the public sector in these working groups, in particular this one, so important. And the only other piece that I really wanted to highlight before I turn it over here is the remarkable and important effort being made by this working group to really think about gender equity and gender and regional representation, not just in the working group, but also thinking about how to translate that into tangible direction and focus on gender. We all know pregnant women and young children face higher risk because of reduced immunity. We also know that the vulnerability to existing infectious diseases is heightened by other health crises at the moment. And yet thinking about all of this, whether it's pregnant women at risk of infection from Vivex, or thinking about research on new antimalarials, thinking about operational research that thinks about gender barriers in accessing care and treatment, the different situations that women face and families face in terms of accessing transportation, accessing treatment and testing in a way that optimizes their limited opportunities to actually go to the health facility. And this is apart from thinking about sex or age disaggregated malaria data, and really thinking about malaria data along the lines of gender. So if we're going to be successful in adopting radical cure, if we're going to be successful in thinking about other ways that these data can be used, it will be critical for us. I wanted to close by saying that APLMA's role is very much in partnership with APMEN to really touch on that policy piece and figure out how we can best support the national programs in the critical role that they play to influence processes, to understand what we can do to amplify their voices beyond not just the national program and the Ministry of Health, but of course, entities such as the Ministry of Finance, where there really is a limited understanding of what the process looks like and a pathway to elimination and how that breaks down when we're thinking about what kinds of interventions are needed to address something like Vivex. So thank you very much for the opportunity. I wish you all a very robust next few days. And with that, I'd like to introduce Dr. Karma Lazine. Dr. Karma, as most of you all know, is the director of the Department of Public Health for the Ministry of Health in Bhutan. She also leads the Communicable Disease Division. Non-Communicable Disease Division, Health Promotion Division, Public Health Engineering Division, and Royal Center for Disease Control. She previously worked in the Essential Medicine and Technology Division under the Department of Medical Services, looking after the Essential Drug Program and Health Technology Assessment. Before that, she worked as Program Manager for the Vector-Borne Disease Control under the Department of Public Health and has worked as a medical officer, mostly in hospitals in malaria endemic areas in Bhutan. She was also the national focal point for IHR, International Health Regulations, in 2005 for Bhutan. And Dr. Karma, I understand, has just returned to quarantine in Thimphu after being playing a leading role in the last few months coordinating national COVID vaccination. It's been an honor to get to know Dr. Karma these past few, past 1 year. Her leadership is tremendous. And with that, I turn it over to you, Dr. Karma.
Thank you, Dr. Sarthak Das. As I speak today, yes, I'm speaking from a quarantine facility in Thimphu. And it was a pleasant experience for me as a frontliner in one of the most affected districts in the southern borders. And Bhutan was fortunate to get both the doses of vaccine, and we have just achieved on 26th of this month, we have achieved 90% coverage of our eligible populations in Bhutan. And it is because of the global solidarity and the support we have received from our neighbors and our partners globally. Today, it's a great honor for me to welcome all the participants to the APMEN Vivex Working Group annual meeting that will be held virtually for the first time, perhaps. Over 155 participants have registered for the meeting from across Asia Pacific region, the US, Europe, and few places in Africa. During these challenging times, we are very thankful to you, especially now, for making time to be with us to discuss what we hope is an exciting meeting with a theme from pipeline to policy and towards optimized implementation. And what is most encouraging is that in spite of being a virtual meeting, the reason you all are here today in itself indicates your passion for this subject of discussion and your determination to work towards a malaria-free world. It's not at all easy these days for all the countries in the world, but we know that this too shall pass, and hope that we all will see you all over the course of the next 12 months as the light at the end of the tunnel becomes brighter. I would especially like to warmly welcome my colleagues who have worked, who are from the National Malaria Control Programs, and colleagues in both the regions, Asia Pacific region, most of whom are represented here today. We are especially very keen to hear from you with regards to your priorities, your questions, and the challenges you face over the coming 12 to 24 months regarding Vivax malaria. We would also like to say huge thank you at this stage to a number of groups and individuals who have helped us both shape the agenda and provided support to organize the logistics around the meeting, as well as those funding us over the coming 2 years. We have to thank APMEN Secretariat Singapore, especially immense gratitude to Dr. Phone. He has been an incredible support to us at this hour. We would also like to thank our newly established APMEN Vivex Working Group Advisory Council for their inputs and guidance. Our facilitators who you will meet later today also for sitting with us and helping us in putting into sessions to discuss group works. They come from a number of organizations working across the region. We also would like to welcome and also thank the chairs and the presenters who have taken time with us for briefings and inputs before the meeting, while planning for this meeting. Finally, I would also like to thank our moderators, Dr. Sandy Lewin and her team at Myanmar Health and Development Consortium for moderating and note-taking throughout this meeting. We hope that you will all enjoy the meeting and learn and have fruitful discussions that we can follow up over the next coming months. With the hope of meeting in person at some stage in the future, I will hand over to Dr. Caroline Lynch to provide you with an overview of the agenda for the next 3 days. Thank you and welcome for this meeting, and hope you have very successful deliberations and understanding of Vivex in our region and globe, and meet our goals of eliminating malaria by 2030. Thank you, and Tashidele.
Thank you, Dr. Karma. I'm trying to find the applause button on Zoom, but I think it must be a different app. Welcome, everybody. I echo what Dr. Sarthak and Dr. Karma said. I'm the co-chair of the APMEN Vivex working group. And I'm just going to go through the agenda for the next 3 days, which you'll have hopefully received via email. I would just like to remind you, as Sandy had said, you know, it's been a tough year. We haven't met face-to-face in a long time. So if you can put your videos on, if your bandwidth will support it, that would be nice. It's nice for the presenters to be able to engage with the audience. So just for today, we've had our opening and we're moving to a pretty exciting and meaty session chaired by formidable Dr. Kamala Streamer from Menzies. We'll hear from Dr. Gonzalo Domingo, Dr. Nina Valencia, Dr. Penny Growell on the latest of the new tools coming out, and also the WHO guidance, the current guidance and processes for change. Towards the afternoon, we'll head towards talking about Operational Research Database and some group work and a poster session chaired by Dr. Prudence Hamade from Malaria Consortium. Many thanks to those of you waking up early in Europe to join us. I would just like to say at this point, there are pieces of the agenda which are particularly stressful for us as organizers because we've decided to be a little bit experimental. So we would ask your patience as we move you off into breakout groups for the group work session, and some of you will be rotated around the posters that we've received from across the region as well. So please be patient with us, both in terms of the timing and also the technology. This would be so much easier in a face-to-face meeting, which, as Dr. Karma said, we hope we can do next year. Before I go on to days 2 and 3, to try and give us a little bit of levity as we talk through these challenging topics, what we would like to do is, if you as participants would just take a photo of something that's around you, something that has made you smile today. And you can upload that to a Facebook page on the second bullet point link, which I think someone is going to kindly put in the chat box for me. And then tomorrow we'll come back to that. So if you just take a photo of something that's making you smile today, upload it to Facebook, and also at the same time like the APMEN Facebook page, and we'll come back to that tomorrow during one of the break sessions. Okay. Moving on to the next 2 days. Tomorrow we'll be talking about policy and towards optimized implementation. So we'll have some sessions on priorities, trying to figure out what your priorities are and what's important to you to achieve elimination. An options assessment toolkit that we're beginning to think about to support trying to figure out which tools will be best in your context, and some policy mapping by Veronica to think through how we move from the evidence into policy and then implementation. We then have some exciting talks from Dr. Kamini Mendes and Dr. Chansuda They're going to talk about adherence from countries that have reached elimination and what we can learn from them, and how we can try and implement that. And then Dr. Tsuda has pulled together early experiences with G6pd, the quantitative G6pd use in some countries in the region, which I think that would be useful for countries to learn from. On day 3, we have Dr. Roz House from FIND in a session titled Show Me the Vivex. And she'll talk about how to potentially optimize placement of these new tools to achieve maximum impact. So rather than trying to take this universal approach, how we can target, especially as we move towards elimination. Then we have our second slightly experimental session and having these lightning talks. And we'll hear from Malaria Consortium, Rollback Malaria Multisectoral Working Group, Dr. Leo Makita from PNG, talking about access and multisectoral approaches to try and get to the more remote populations. And then we move into group work session again, where we'll talk about what strategies are being used to increase radical cure. As Dr. Sarthak was saying, the key thing is to try and get these tools, or even the current tools, down to the most remote populations where caseloads are probably the highest. So we'll have some discussions around that. To finish, what we're hoping for is a closing from APMEN, but before that, perspectives from the National Malaria Programs. And we can hear from them as to what they think of the work plan and also how they feel the annual meeting has gone as well. So I'll stop there, and I'm going to move to, we'll transition to the first session by this video, at which point Sandy will pick things back up with you all. Thank you very much.
We need to move from talking about these aspirations of elimination by 2030, and we need to go into action.
In January 2021, Medicines for Malaria Venture took on hosting the APMEN Vivax Working Group.
The goal is also to assist the national programs in proactively identifying implementation bottlenecks and help them progressively tackle these issues.
In particular, the working group provides a platform for countries to come together, share their experiences, and learn from each other.
During this time, the group will be chaired by Dr. Carmela Zine and co-chaired by Dr. Caroline Lynch. An advisory council has been formed to support the group.
What we actually aim to do is reach out to the partners in the country to keep up to date with the ongoing activities.
Key topics for the upcoming annual meeting are recent updates to radical cure tools, policy process mapping, country priorities and the options assessment tool, G6pd testing and patient adherence, and most importantly, expanding access to radical cure.
I hope through the APMEN Vivex Working Group, we can draw together and share evidences and best practices that answers key questions the national malaria programs may have.
Eliminating malaria before 2030 across Asia Pacific will not be possible without addressing Vivex.
And we look forward to seeing you all there and taking this conversation forward. Thank you.
Thank you very much for this introduction and the video. I would now like to introduce Dr. Kamala Thrima, who will be chairing the first session. Dr. Thrima is a CSL Centenary Fellow at Menzies School of Health Research. Her main research interest is to develop and optimize treatment programs against Vivax malaria in Southeast Asia and in the Horn of Africa. Her research program spans from clinical trials and epidemiological studies to policy and implementation research. She's also a lecturer at Charles Darwin University. Dr. Kamala.
Thank you very much, Dr. Sandy. Welcome to this first session. It's lovely seeing you all, even not face to face, but in the online environment. And I think I echo Carrie's sentiment about hopefully the next Vivex Working Group meeting is going to be in a room with everybody together. I'd like to introduce the first 3 speakers for this session. The title of the session is Out of the Pipeline. So the idea really here is to provide an update on all things new around Vivex. Our first speaker is Dr. Gonzalo Domingo, who is been part of the Vivex Working Group since ever, I think. He heads the malaria diagnostic portfolio at PATH and serves as the Senior Scientific Director within PATH's Global Diagnostic Program. And he will provide an update on both Vivex as well as G6pd diagnostics. The second speaker is Dr. Nina Valecha, who served for many years as the Director of the National Institute of Malaria Research in India. And she's going to talk about the WHO current guidance for treatment of malaria and the processes for changing policy. And our third speaker is Dr. Penny Grewal from MMV. Penny is a senior consultant to the Access and Product and Development team at MMV. And she will give us an overview of the most recent developments in regards to radical cure. I'm looking forward to all three talks. There will be a Q&A session after the three talks. So don't hesitate to put your questions in the comment box in the meantime as they come to your mind, but we'll look at them all together at the end of those three talks. And we certainly try to answer all of your questions and try to summarize them. So please be patient with us. For those questions that might not get answered, I'm sure we have a follow-up mechanism in place. So with no further ado, Gonzalo, can't see you. Oh, okay, there you go. I'm handing over to you, Gonzalo.
Thank you, Kamala, and thank you to the organizers for giving us the opportunity to present this work. We can go to the next slide. I'm going to talk about point-of-care tests for the diagnosis of Vivax malaria, tests for G6pd deficiency, and some exciting opportunities to really see how these may improve access to a radical cure. If we go to the next slide, please. Yes, I'll try to speak up, sorry. Next slide. If we think of the life cycle, when we diagnose malaria, we really focus on the blood stage parasites. Can you click forward, please? Sorry, can you hear me? I'm not sure why the volume is low. Is this? Hello?
Much better.
Okay. The problem we have with Vivax malaria is that when it presents in the blood stage, when people are feeling symptoms, they have very low parasite density. And the diagnostic tests that we most typically use to diagnose malaria are actually the least sensitive, with RDTs actually performing typically worse than the microscopy, even at the point of care. So ideally, we want more sensitive tests to identify those Vivax cases so that we can actually treat them. The other stage of Vivax malaria that complicates really expanding access to radical cure to everybody who has Vivax malaria is the liver stage parasites. Can you click again, please? And these are notoriously difficult to detect. They're not visible. They don't circulate in the blood. There's exciting work being done to develop serological assays to know that whether someone has recent exposure to malaria, to Vivax, and therefore has a high chance of having hypnozoids. But these are the parasites that we're trying to eliminate or cure so that the individual will not then suffer from multiple relapses that can lead to sustained morbidity and bad consequences for the patient. I'm going to focus primarily on the blood stage diagnosis of malaria, what actually happens at clinics when people present to a clinic feeling sick. We go to the next slide, please, and the next slide. Rapid diagnostic tests actually diagnose the presence of proteins from malaria parasites or antigens. And for Plasmodium vivax in particular, what we detect is lactate dehydrogenase, or LDH. And what you can see from the graph on the left of this screen is that actually the Plasmodium vivax produces very little LDH per parasite compared to HRP2 and LDH produced in falciparum. So RDTs that work well for falciparum actually have to perform better to be able to be as accurate in diagnosing malaria for Plasmodium vivax. And the ones we have at hand at the moment are actually a little bit challenging, have poor limits of detection for LDH, and therefore actually don't do so well in detecting all cases of Vivax. One of the things I do also want to highlight, because I'm going to be talking about this, is that we can now measure quite accurately the LDH, the antigen concentrations in the blood of patients through tests that CDC has developed, and this one, the Qplex, that was developed by Quansis. If we go to the next slide. I think what's quite exciting that we're seeing that's already now currently available is that there are new tests coming on board. This one in blue is one by Rapigen from South Korea that have got improved limits of detection of LDH. So this graph, what it shows is the probability of the proportion of positive RDTs in samples at different concentrations of LDH antigen, which corresponds to parasite density. So the more that curve moves from right to left, the more sensitive your test is, and because it's detecting lower concentrations of LDH. This is data from an analytical work we do in our labs in Seattle, where we evaluate the RDTs against recombinant protein in clinical samples, and then we can model the limit of detection. So the gray line on this graph, all the way to the right, is what the current WHO PQ RDTs detect, and actually we get about an order of magnitude improvement in LDH concentrations with these new RDTs that are coming. And so the blue line is the rapid PV RDT, which is ERPD approved, and then the red line is an example of an RDT that's performing somewhere between those. If we go to the next slide. So that's data generated in a lab. It's analytical performance. We want to try to correlate that to what happens in a clinic, what will happen in a clinic. What this graph shows is essentially two histograms. The red histogram or distribution of LDH is samples collected from febrile patients. In this case, 114 clinical samples from febrile patients. The big bias in this graph is that these are microscopy positive patients from samples provided by FIND and Discovery Life Sciences. And then the blue graph, the blue histogram is the distribution of LDH concentrations, which correlates very closely to that of parasite density in asymptomatic cases. We found these in collaboration with Francois Noston's group from SMRU. These are from 349 samples in Myanmar. And so you can then overlay on that the limit of detection of the RDTs. So that green dotted line is the current WHO pre-qualified best-in-class RDT, and anything to the right of that dotted line is what the RDT would detect. Anything to the left is what it would miss because it's below that limit of detection of that RDT. And then the blue line is actually where the new RDTs are coming in. So what you can see is that the changes of those distributions will really affect what that means in terms of sensitivity. If we go to the next slide. So using those distributions, what we can show is that in asymptomatics, the current RDT would only detect about 4%, would have a sensitivity of about 4%, whereas the new RDT you'd anticipate in that population to detect 21% of those cases, or 22%. And then in febrile cases, it goes from 91% to 94%. That, just a reminder, this table really highlights that there is this inherent bias. First of all, not many samples. There's an inherent bias that the febrile cases were detected by microscopy. So there will be positive cases that were missed because they were submicroscopic, whereas the asymptomatics were detected by PCR. If we go to the next slide. So in summary, the RDTs with improved limits of detections for Vivax are becoming available. There is one available now, the Rapigen, and we anticipate more coming on over the next couple of years. These are likely to improve case management and identify lower density infections. And further improvements are needed to meet the detection limits of PCR. They're not going to cut it. LDH is not going to take us where we need to be for example, surveying asymptomatic populations. I didn't talk about the other technologies that are coming on. Many people have already heard of the Hemex Gazelle device that detects hemozoin. That seems to be detecting Vivax cases quite well, at least equivalently to microscopy and better than RDTs. And then I mentioned briefly the promise of serology to address the hypnozoite parasites and actually provide access to a broader subset of Vivax infected individuals beyond clinical management. So if we go to the next slide and forward again, I'm now going to switch gears to talk about G6pd deficiency. As many people know, currently the clinical laboratory tests for G6pd deficiency are either quantitative and quite involved. They require measuring enzyme activity with one instrument and then hemoglobin with another instrument, typically actually a CBC counter, and the less complex form being the qualitative fluorescence spot test. Both of these instruments are fairly complex and involved, and also they do have inherently temperature control to measure that enzyme activity. If we go to the next slides, those present a major barrier to access of these to G6pd testing if you're going to then provide primaquine or tafenoquine safely. A few years ago, Access Bio introduced a qualitative test, a point-of-care qualitative test, and it really met a lot of the operational characteristics that we want in a test to be able to test for G6pd deficiency. There's no instrument. It was very similar to an RDT in terms of complexity. Challenges are that it does not correct for operating temperature, so that has an implication for performance, and it cannot accurately differentiate in females with intermediate G6pd activity from those with normal, which is a limitation if you want to use it to provide access to tafenoquine. And a very nice study from Ben Lay et al. Doing a meta-analysis of the studies summarized the performance of this test. Unfortunately, this test is no longer available, but it is the closest we've been to having a qualitative test that is fit for purpose in operational settings. If we move forward to the next slide, as I mentioned, there were some limitations. The interpretation of this test was quite challenging because there was a change in the hue and it wasn't even. The operating temperature is very hard to make a qualitative test to work that works over a broad temperature if there is no temperature regulation or accounting for that. And the access bias test had no control lines or were there and did not provide any controls. If we go to we click forward, and then again, actually. We are seeing new tests. Access Bio is making a new test that has control lines. We're not sure how soon that is from entering the market. And Humatis has made a test that also has a control window. Both these tests need further clinical evaluation, but they are progressing and address some of the limitations. And also, we've demonstrated the feasibility of using recombinant protein to develop controls that are fit for purpose to quality control assure these products in operational settings. If we go to the next slide. In contrast, the quantitative and semi-quantitative point-of-care tests are a little bit more involved. They require an instrument, but they do actually accurately diagnose females with intermediate G6pd activity, which is actually quite important in terms of informing treatment with tafenoquine, and then from a G6pd deficiency diagnosis actually provides equity in terms of diagnosing females are the same standard as males. It does correct for temperature, which actually makes them more accurate over the whole range of operating temperatures that we find malaria clinics operating under. They do have some sample prep requirements. They're not as simple to use as the qualitative test, and they require an instrument. If you click forward, the test that is most advanced in terms of clinical evaluations and it's the only test, G6pd test, that has Global Fund ERPD approval, is the standard test by G6pd test developed by SD Biosensor. If we go to the click forward, it's a semi-quantitative test. It has thresholds on the label that align with the WHO PQ classification, and you can use those thresholds to diagnose G6pd male deficients, female deficients, and intermediate females, as well as normals, obviously. If we move forward, clinical performance data is beginning to come out. We expect the Brazil data to be published, and shows that the test does meet purposes in terms of performance under clinical studies. If we move forward, I realize I'm running over time, and move forward again. So the challenges are the interpretation, the requirement of instrumentation, but that's also something that provides accuracy, and the shelf life stability. We know that it's currently at 12 to now being extended to 18 months. If we click forward, and again, so there are things that are happening to make this, to resolve this. Manufacturers are exploring smaller number of units per kit to help distributing to account for the short shelf life. As well as alternate platforms. There's actually quite a robust pipeline of products coming through that operate on different platforms that may help address the stability issue. And in terms of its ease of interpretation, a lot of partners are working on actually making available easy guides to support training to interpret these tests. Some of these resources are available in our GORCOP facility. Can we go to the next slide? So in summary, there are point-of-care tests available designed to meet the need of malaria community. They have adequate performance and adequate complexity and workflow. They're not perfect. The qualitative tests, unfortunately, the new generation need more qualification in clinical studies. They're constrained by operating temperature and have no control lines, but that's been addressed by the new generation. And the quantitative tests, they require instrumentation, which inherently constrains access, and the shelf life can be improved. It's nowhere near the 2 years of RDTs. If we go to the next slide, we can move forward. So there are a couple of products, the Rapigen Biocredit RDT that has lower limit of detection for LDH. There is no clinical data. The data I showed was based on data we ran in labs and then superimposed on clinical data. So there is an opportunity to conduct clinical studies to evaluate their performance in intended settings. For the point-of-care test for G6pd deficiency, there are extensive clinical studies to support the analytical performance of these products. And those are going to be published over the next few months. But there is an opportunity to conduct operational studies to assess their use under programmatic circumstances. And I believe Dr. Shansuda will be talking about this later. And then critically, because these products are commercially available, there is really an exciting opportunity to understand what happens if you combine these tests in terms of actually detecting more cases of Vivax malaria and what proportion of those would get radical cure. With that, if we go to the next slide, obviously like to thank all the study participants, all the field and lab teams that particularly presented data from work with SMR, with Francois Nelson's group in Myanmar and SMRU, and then also Dr. Delio Pereira from CEPEM in Brazil, and Dr. Marcos Acedo from FMTVD in Manaus, Brazil. But all the partners have been working with us, private sector, manufacturers, and lots of people I can't mention. But thank you all again. Sorry for going over.
Thank you very much, Gonzalo. That was a quick train ride through all the diagnostics, and I appreciate it's really challenging to put this all into 15 minutes, but I think an amazing overview. And I'm seeing already some questions there in the chat room, so please keep them coming, and we're trying to synthesize them for the end of the session. So with this, I'd like to hand over to Dr. Nina Valecha, who is going to talk us through the WHO guidance for treatment of malaria and the process to actually change policy so that we can get all those new tools into policy and ultimately practice. Nina, over to you, please.
Thank you, Chair, and good morning to all. My presentation will be in two parts. One is the current guidance on treatment of malaria, and the other is the process for policy change. May I have the next slide, please? So I'll be talking about the WHO guidelines, which are now on the web-based platform. Next slide, please. So to start with is the preventive chemotherapies. I'm not restricting myself to Vivex malaria, so I'll be covering all aspects. So in the preventive side, we have intermittent preventive treatment for malaria and pregnancy. And the recommendation is to use SP from second trimester onwards, and the doses need to be given at least 1 month apart. And the objective is to have at least 3 doses. And similarly, for intermittent preventive treatment of malaria in infants, this needs to be preferably coordinated with the vaccination schedules for better compliance. And also SP is the treatment, the choice, drug of choice. And it is generally two doses are given. And also for when in countries, and these are both, as I said, in fact, all preventive chemotherapies are for the high transmission areas, endemic areas. And the seasonal malaria chemoprevention is where the transmission is seasonal. There, children under age of 6 years can be given amodiaquine plus SP during the transmission season. And let me inform that IPTI recommendation is being now discussed, and this with there is an update expected in 2021. Next slide, please. Coming to the case management, we have heard about the diagnosis just now from Gonzalo. So the good practice statement is that we should diagnose each and every case of fever by parasitological test, whether it's microscopy or RDT, and then treat a confirmed case. This, of course, is a good practice statement. Sometimes it is not feasible, but this needs to be in place. When it comes to treatment of uncomplicated malaria, there are 5 artemisinin-based combination therapies which are recommended by WHO, and they can be given for all types of malaria except in pregnant women in their first trimester. But yes, in Vivex malaria, artesunate SP is not recommended. And artesunate pyronaridine, I would like to especially mention here, this is a new ACT which has already been in the list of pre-qualified medicines for malaria of WHO, and also model list of essential medicine. It is approved by stringent regulatory agency. So the guidance from WHO is that countries can consider including this in their treatment guidelines, although the formal recommendation is being updated in 2021, and then it will be part of the other recommended ACTs. Next slide, please. And of course, for falciparum malaria, Vivex malaria has a problem of relapse. But in falciparum malaria, we need to target gametocytes for preventing transmission. So in low transmission areas, low dose of primaquine is recommended to all patients, confirmed cases of falciparum malaria, except of course where primaquine is contraindicated. And in this case, G6pd testing is not required because it's a very low dose with a minimal risk. So this is another use of primaquine besides treating relapse of Vivex malaria. Next slide, please. Now, as I said, other species, so they can be treated with artemisinin-based combination therapy or even chloroquine, where the susceptibility is maintained. So these are both the choices. And to prevent relapses, I won't go into detail. My next speaker is also going to talk about it. But the standard recommendation is 14-day treatment in all transmission settings. Of course, it cannot be, Primaquine cannot be given to pregnant women, infants under 6 months of age, women breastfeeding infants under 6 months of age, and even the women breastfeeding older infants if they are known to not to be G6. We don't know the status. If we know, then it's a different thing. And also in case there are G6pd deficient patients, and then weekly schedules for Primaquine can be given. But most of the countries, the feasibility of doing G6pd at point of care, we have just heard the presentation, is difficult. So when that information is not available, if the risk and to weigh the benefit and risk, if the relapse rates are very high in area, but the G6pd deficiency in that area is low, then it can be in favor of Primaquine, but otherwise it has to be really a choice at local level. Depending on the G6pd deficiency status of the population of the community, as well as the risk of getting a relapse. Next slide, please. And as regards severe malaria, parenteral artemisinin are the treatment of choice, and especially I'd mention here artesunate, which can be given intravenously, and it needs to be given at least for 24 hours before it can be substituted by oral dose of ACTs for 3 days. For children, there is a slightly per kg higher dose based on the pharmacokinetic modeling. And if artesunate is not there, artemether intramuscular can be given, but this should be in preference to quinine. Earlier recommendation was artemisinin or quinine. Now we know the artemisinins are much better than quinine. There is a clear-cut evidence. Next slide, please. Now, all these recommendations are there. We can see that, but what is the process to get these recommendations in place? And also then what is the process for updating? So I'll be talking about that briefly. Can I have the next slide? Now, guideline, we know, of course, is any document which is developed which contains a recommendation, whether it is for clinical practice or public health policy. And of course, they address something for which there is uncertainty, or we want to update, or there is an unmet need from public health point of view. And during guideline development process in WHO, it is ensured that process is explicit and transparent. It in multidisciplinary, it involves all relevant expertises, and there is a minimum risk of bias, and there is a balance of policies, intervention, and benefit and harm. We are talking about Primaquine benefit and harms. So one has to consider that. And also the evidence used, which is there are evidence review groups which go through the available evidence. This evidence is the one which is publicly available or in public domain, like the publications and other documents. And also the recommendation need to be such which can be implemented easily, and also which can be adapted to the local setting and context. Next slide, please. So in 2019, there was an online consultation, including partners, stakeholders, to identify what do we need as new topics for which need updating of recommendation or new recommendations. And suggestions were gathered. And then, of course, there was an internal review as well as to which recommendation need to be updated or discussed further. And the standard guideline development process involves now the guideline development groups have been constituted for different technical areas, and the process is on of the review and drafting of recommendation, and even the PICO questions are being discussed. And there are some malaria experts also which are working as editorial working group, and so that there is consistencies and comprehensiveness is ensured, and they are part of the guideline development group meetings as well. Next slide. And now the current recommendations, which were earlier in the form of documents like treatment guidelines or control guidelines for vector control, and these were published in print. But now these are, they are as a single resource. WHO guidelines all are at one place, and they are available on web-based platform. And there are relevant links also where you can see the evidence as well, which has been taken into consideration while framing those recommendations. And most importantly, there is a feedback tab also, which can, one can get feedbacks from those who are using those guidelines so that they can be reformed or those things can be considered if there are any challenges. And they can be reviewed, and these are sort of like living guidelines so that they can be reviewed and updated very soon as the process of a new updated guideline is there. This is the advantage of having an online platform. And also there is one aspect which is important, that it has been realized that one size doesn't fit all. So definitely these are recommendations, and these needs to be adapted. The countries can, or member states can adapt these according to the local data available, and they can be tailored to local setting. Of course, for that support definitely can be provided, but it is not that these are not supposed to be prescriptive for the users. Next slide, please. Now the steps which are in the pathway. And thanks to Pedro who shared his slides. So first step is better anticipate, as I mentioned, the products or strategies which are likely to be key in the future, and they need to be identified, and then only the development of recommendation is started, and especially, the aspect that what the countries need to do for those particular recommendation, or based on the new evidence available, and also the how to optimize the uptake of these recommendations, the way they are shared. As I said, this is now an online platform. As such, it is the system from which the implementation or the dissemination is easy, and the outcome is the new recommendation implemented and the impact is achieved. And of course, the feedback tool, as I said, is there, which can help us improve that. Next slide, please. Now, as the first step, as I said, first is the defining the unmet public health need, and then defining the preferred product characteristics of products or strategies which can address those needs. And then, of course, scanning the pipeline of new products and determining which has a sufficient evidence. And of course, all this process needs to have a transparency and predictability, so that the R&D space also can be shaped well. Next slide, please. And in the recommendation development process, it is a very rigorous process. It involves, as I said, identification, and then, there are guideline development groups, evidence review groups, external review, and the GRC approvals. So all that takes place, and of course, the final approval of Malaria Policy Advisory Committee. So this whole process is involved. And there is another new process which has been started, that that there should be coordination with the pre-qualification process, so that when the recommendation is there, the quality product is available out of the global standard. So there is a coordination now with the WHO pre-qualification team and recommendation development, so that along with when the recommendations are made, side by side, the process of pre-qualification is also completed, and the listings can be at the same time. This will really help the uptake of the products which are recommended. Next slide, please. And as I said, regarding the optimizing uptake, the new guidelines, they are available on the easy to navigate online platform. And also definitely there is a effective feedback loop is needed, which definitely will help us improving the guidelines or updating as and when required. Next slide, please. And of course, the pathway has been designated to deliver timely, high quality recommendations for malaria endemic countries. And the processes are transparent, consistent, efficient, and predictable. Next slide. And there was a question for me, I mean, that what are the timelines? So as I said, there are different guideline development groups which have been established, and they are reviewing the new ACTs, as I said, artesunate pyronidine, and also the treatment in first trimester of pregnancy, and the dosing of primaquine, which will for anti-relapse treatment, which is being debated, and the outcomes are expected, or recommendation are expected in September 21, even for IPTI. In September 21, we are expecting the recommendation final. And then there are other related to the elimination and chemo prevention too on IPTP, SMC, school children. These are also planned in 2021. And point of care diagnostic test, including the pre-qualification, and this also is expected in late 2021. The process is on. And there are other groups also which are deliberating on IPTP and also the Vivex malaria in pregnant women. So they still have to, I mean, I can't say the dates here. So these will be definitely they are being taken up and will be discussed, and the recommendation will be available soon. Next slide, please. So I would like to thank Pedro specifically for sharing his slides. In fact, he could not be here for this presentation, but he did share his slides with me. Thank you very much.
Thank you very much, Nina, for this great overview. Much broader than Vivex, obviously, but really important. And we might have to talk about the TBD in the timeline for the Vivex treatment guidelines in the discussion. I'm sure there are some questions around that. So again, encourage everybody to post their questions in the chat while you're listening to the next talk. And with this, I'd like to ask Penny to take over, and she's going to talk about the new treatments for radical cure. Penny, over to you, please.
Thanks, Kamala. Good afternoon, everybody. And I'll give a quick update on the Vivax radical cure treatments and hopefully give us enough time for the many questions that are already being posted. Next slide, please. So let me start with our mainstay of radical cure treatment, which is Primaquine. Nina's already talked about it. And as she was mentioning, in September of 2021, there's going to be the WHO Evidence Review Group recommendation on the high dose course of Primaquine, which is 1 mg/kg. And with that also, there's going to be a question of the much awaited guidance in terms of whether G6pd testing will or will not be mandatory with the higher dose of Primaquine. Next slide, please. So let me now move to Tefenaquine, which is the single-dose radical cure treatment, which is indicated for patients 16 years and over of age. They have a very similar non-eligible patient population, namely pregnant women. However, the G6pd threshold, activity threshold, is higher than that for Primaquine. For Primaquine, you need a 30% G6pd activity, minimum 30% activity. For Tefenaquine, it's 70% or higher. And again, the breastfeeding indication, clearly women who are breastfeeding infants who are G6pd deficient or unknown G6pd activity are not eligible for Tefenaquine. Tefenaquine can only be used with chloroquine as a blood stage treatment. And as Nina's already mentioned, I think Gonzalo also mentioned this, the G6pd testing is clearly mandatory before the use of Tefenaquine. And for that, you need a test which can differentiate between normal, intermediate, and deficient G6pd activity. The drug has been approved already in 2018 by the US FDA and the Australian TGA. Brazil and Thailand approved Tefenaquine in 2019 and Peru in 2020. I'd just like to say a few words of the ASEAN joint assessment that was conducted in the Asia-Pacific region, which is essentially bringing together regulatory agencies under the guidance of WHO, together with the therapeutic assessment from the FDA and with the support of the Thai FDA, to review the dossier of Tefenaquine. And that was done in Vietnam, the Philippines, and Myanmar. And at the moment, it's going through administrative review before it will be formally approved in these countries. Tefenaquine is also being assessed through the regular approval process in India, Pakistan, and Ethiopia. From a WHO policy perspective, as Nina has mentioned, Tefenaquine will only be reviewed once there has been a G6pd test that has been pre-qualified by WHO. And the PICO questions have already been developed for the systematic review of difenaquine, although there are clearly no timelines at the moment. Next slide, please. So pediatric populations are hugely important in Vivex, as we all know. And as we also know at the moment, what many countries are being obliged to do is take Primaquine tablets and break them to half. And the tablets being so small is being resulting in under or overdosing of the pediatric population. So we're excited to tell you that we have 2 pediatric formulations under development for Primaquine, dispersible formulations of both a 2.5 milligram and a 5 milligram tablet. In addition, W1 is doing a meta-analysis on the safety and efficacy of pediatric Primaquine, which will also help determine the appropriate dosing of the drug. The regulatory pathway for Primaquine is going to be through WHO pre-qualification, which we anticipate in 2023. We also have a dispersible sweetened pediatric formulation of difenaquine for children over 6 months. This is currently under review by the Australian Therapeutic Goods Assessment. It's actually quite interesting. What we've developed is a blister pack with 2 tablets on one side and 1 on the other side. And so this would allow to pull together the right doses. It's going to be a proposed dose which varies by weight band. And we've all learned from the Coartem experience in which it's very difficult to estimate what quantities you need for a given weight band. So it's going to be provided in a pack of about 30 tablets. So countries can then actually put together the appropriate dosing for the patient population they have. The submissions to malaria endemic countries are going to be made after approval by the TGA. Next slide, please. So I think if we look at the 3 new tools we have, they are both opportunities and challenges. The biggest challenge, of course, is for Primaquine is clearly around compliance. Healthcare workers being hesitant to give the drug, patients not complying with the full course of treatment because they feel better. And I think the biggest liability we have around asimilaquinoline is the G6pd liability. As we all know, there's a perceived feeling of safety around Primaquine because you can interrupt treatment. However, some of the evidence shows that it's not as clean as people believe it is. There may be a need for G6pd testing before high-dose Primaquine. There's definitely a need for G6pd testing before difenaquine. And G6pd testing is great. We have new tests available. We have reliable tests, which is very exciting. However, it requires a change in the way in the patient flow and also applying new treatment algorithms, which may be complex. The cost implications. There is also the potential to use G6pd cards for male patients. And then, of course, we've got all the complexity around how do you use that for G6pd intermediate patients. Next slide, please. If I would look more closely at difenaquine and say, what are the limitations of the current treatment? That's going to be very much one of our big limitations is that difenaquine needs to be given on day 1 or 2 of chloroquine dose. The reason for that in the label is simply because that is how the drug was given during clinical trials. So what we're trying to do right now is say, okay, what are the chloroquine concentrations that are required in order to extend the dosing window between chloroquine and difenaquine, and then possibly look at some modeling data in order to see what needs to be done and what could be done, and then decide on next steps. The next limitation at the moment is there's no, the next limitation is clearly there's no data at the moment in the use of difenaquine with any ACT. As you know, the study was done in Indonesia, the inspector study was done, and the results were very disappointing. So what we're doing are 2 stages to try to understand what happened within that study. One is the pharmacokinetic analysis on the blood samples. However, with COVID and all this complexity around it, that is still work that is pending. In addition to that, there's been a lot of ongoing in vitro and in vivo work to investigate the potential synergistic or antagonistic effects of different blood stage treatment with difenaquine and with chloroquine. And I think those results will be shared before the end of the year. Next slide, please. If you look at the risk management plan for difenaquine, the two things which are planned, one is clearly the mandatory G6pd testing I've been talking about, and the other thing is clearly training healthcare workers, both on G6pd deficiency, the need for testing, the signs of acute hemolytic anemia, and safety reporting. Next slide, please. Now, if you look at pharmacovigilance for difenaquine, it's been very interesting. As you know, difenaquine is available on the US market. Together with the CDC, there's been a post-marketing study going on for the use of difenaquine. There have been about 3,500 prescriptions of difenaquine. That doesn't really translate into the number of treatments given. Nonetheless, from that study that's been ongoing, there have been no reports of adverse events. There's only been one report of lack of efficacy when given with artemisinin and epinephrine. In Thailand, there has been, the Thai FDA has been working with WHO on the 3S program, and they developed some very good guidance in terms of giving very clear guidance in terms of roles, responsibilities, how pharmacovigilance should be done, including a very detailed description of the adverse events and profiling and the likes. So that's very exciting work, and that's going to be implemented also within the framework of the planned study or the planned feasibility study with the use of G6pd testing before radical cure. The study has clearly been delayed because of COVID. And then once the drug has been approved and made available through normal channels, then there's going to be a stimulated reporting, which is planned by the Thai FDA. In Brazil, there's also a planned feasibility study, and within that framework, there's also planned follow-up of all patients with on day 14 and day 7 using a digital app. In addition to that, there's going to be patients coming back at day 5 for an assessment of early signs of hemolysis. And I believe that's my last slide. So as you can see in a nutshell, there's a lot of work that's ongoing. There are a lot of planned work to see how can we get these drugs out there safely and effectively. And on that, let me hand back to you, Kamala.
Thank you very much, Penny. Yes, lovely. Thank you very much. So there are heaps of questions in the chat box, and I will try to make sure that each of the panelists gets some questions and trying to direct them to you as they come in. Nina, I might start with you, if that's okay. There were a couple of questions around the adaptations of the general guidelines to the local context, and you talked about the need to tailor those guidelines and to be non-prescriptive and to have global guidelines that then can be adapted to the local context. Can you talk a little bit more how this should work out in reality and kind of what the mechanisms are behind that or that support that?
Yeah, thanks. And now, of course, things are changing. We have rapid tests as well, but a requirement of a lab at a higher center and all those stuff. So basically, so these are the things which then we can't be prescriptive, that don't get taken care of. And there was a study which was done with MMV collaboration as well, like what can be done. So the way was that, you know, there can be a monitoring of these patients in the way they were cards given to them to, and the side effects were told, and the person can monitor, and the treatment can, I mean, every day that, and also whether they can be, the community worker can be explained what to look for, and so that the treatment can be given safely. That may not be the ideal way, but still, if it has to be adapted to local context, the countries do like that, and they monitor in a way they can through visuals, or there was a card given to them. And even like the change of policy, which based on the drug resistance levels, or if the efficacious treatment failure is more than 90%, one needs to change the policy, and also the use of fixed dose combinations, which is you know, preferred and also recommended. But some countries prefer to use, I mean, they are not using fixed dose combination, but then the support is given there and advice is given on how to, monitor the efficacy and how that the implementation of using those medicines can be proper. So whatever the guidance is, of course, that there is an ideal guidance, but then if the countries are not able to do, or sometimes they want to use a product which they feel is better for them or the efficacy is good, so definitely support is provided and technical guidance based on the requirement for that particular country or region or area, or even at a subnational level. Over.
Thank you very much, Nina. I might move to Gonzalo because there are a couple of more technical questions around the diagnostics, and then perhaps we have time later on to come back to some of the policy, to the additional policy question, and then also to some of the questions around treatment for Penny. Gonzalo, so there were a couple of questions around the comparison of the care start compared to the new tests, the Humacin, the new products, and perhaps you can talk a little bit about that. There were a question about the cost of the biosensor, and I might just add to is that cost kind of prohibitive in terms of implementation, and then we might get to some more later on.
So in terms of the, thank you, in terms of the performance of the Humacin and the new Care Start test, unfortunately, we haven't seen a lot of clinical data. We have looked at them in our laboratories in the same way as I described for the RDTs, and they perform at least as well, and there are an improvement over the Care Start test that we've all got to know over the previous years. So that's very exciting. With whether how they will perform at the point of care in clinical settings, we haven't conducted those studies yet on our side. With regards to the cost of the biosensor, SD Biosensor is committed to an ex-works price for malaria endemic countries of approximately $300 to $350 US per instrument and $3.50 per disposable. What that translates to in country varies from distributor to distributor and how it's procured. And that's the same experience we see with the RDTs. What that means, whether it's prohibitive or not, it is significantly more expensive than current RDTs. I think, especially without there being competition, that's an issue. But on the flip side, many countries are approximating elimination, and actually it doesn't add up to a lot if you add up how many cases you need to be able to manage over the year. But that's a math that access people are better suited to answer.
Yeah, great, thank you. And perhaps just briefly for a clarification for the RDT, so the Care Start RDT not being available any longer, is that just through the Global Fund mechanism or in general? That wasn't entirely clear to me.
So it's no longer available through the Global Fund. Access Bio still continues to be under hold to address quality issues with WHO PQ. I should also mention, I think it's important to clarify that neither the RapidGen RDT that I mentioned or the SD Biosensor are WHO pre-qualified. And as Nina pointed out, that is a condition for the WHO. So that is still a step that requires to be addressed with those products.
Yeah, thank you very much. Penny, I might move to you next. There was one question around the expected timeline for the conclusion of the ASEAN 3-country review of tafenoquine. If you could comment on that, if there is a timeline.
So currently, I think we're reaching the end of the process, so it should be done before the end of the year.
Brilliant, that is a clear answer.
And if I could just make one quick comment, I'm just reflecting during this talk that, at my first APMEN Vivax working group, all of these new tools were sort of pipe dreams. And it's really a very, very exciting time for Vivex because we actually have new tools. And it's sort of incredible because we've always been talking about how we are going to overcome the G6pd problem. And Gonzalo showed exciting tools. The whole compliance issue, we have a potentially shorter course of primaquine, we have a single dose tafenoquine. So for the first time, we can actually say, yes, we've got something in Vivex, and we can actually get going. So I'm just very, very excited about that.
Yes, I echo your sentiment. I think we all are. So we just have to and I'll put this in very big, whatever they're called. We just have to put it into practice and implement it. There was another question around the and again around timelines, and those are very challenging questions. I appreciate around the timeline of the pre-qualification on the G6pd test, and what would be the recommendations for countries to start to use the G6pd test at point of care before WHO pre-qualification. Nina, perhaps over to you.
Yeah, as you said, difficult to answer, but as I said before, end of year, this is expected. And I mean, I think September or October 21, I mentioned. But yeah.
Okay, yeah, great. And again, perhaps staying with you, Nina, one of the questions, and I mentioned this briefly after your talk about the expected timeline for the Vivex recommendations, and appreciate that you probably can't give us a date there, but can you perhaps talk a bit more about the timelines in general for this 3-stage process that you described, and give us some examples for that?
Yeah, this has been recently started, and then, as I said, there is a framing of PICO questions, guideline development group meetings, and then the external review, and also the evidence review groups give input into that. So, I mean, I won't like to commit any specific timelines, but you know, for the recent ones which I'm observing, it has taken about 6 to 8 months. But yeah, it depends on the topics, and there are many other issues. So I mean, I can't define exactly. No, yeah.
Yeah, that's fine. Perhaps again, before we have to close up, Gonzalo, you briefly mentioned other platforms that might improve stability. Can you talk a little bit more about those and how they, you know, where they are in the pipeline?
So in contrast to malaria RDTs, where they're all on the same platform, there are a series of G6pd tests that use different ways of measuring the enzyme activity. That means that they have different substrates, some involve additional enzymes or not, and that just gives an opportunity to have different shelf lives in that. Unfortunately, I think it's still a good 18 months before we see any of these products entering the market, but it's exciting to see that there are you know, that we can anticipate more than the SD Biosensor coming up in the future into the market, which hopefully will also help with the pricing moving forward.
Yeah, brilliant. Thank you very much. I know there are heaps of other questions still in the chat box that we won't get to, unfortunately, so I'm sure Kerry and the team have some mechanism for you to somehow get feedback on some of those other questions that we weren't able to address today. I'd like to thank you for your participation, for all your questions. Thanks to the speakers for their contributions. And I think I'll hand over to Sandy.
Thank you, Kamala, and to all the presenters. It's been a very interesting session. We'd like to now wrap up the Q&A session and maybe go over to complete a very short poll to tell us what new tools you would like to hear more about for this afternoon. So I will hand this over to the Secretariat here, Jess. So if you can just click on what topic you think you'd be interested in. Okay, thank you. I think as the poll goes on, we'd like to move to the next session. We'd like to also take a group picture of everybody who's here. So could I ask everybody to turn on your video? If you haven't done so already, I'll just take a few minutes. So it would be good to take a group picture. Thank you very much.
Gary, stop screen share, please. Screen share, stop, please. Gary, yeah.
G. Dr. Pone, are we good?
Just a moment, because of a lot of people. So.
Okay. Everyone say potatoes.
Yes, finished. Thank you very much.
Great, over to you, Sandy.
Okay. Thank you. Welcome back, everyone. For the next session, I would like to introduce Dr. Prudence Amade, who's a Senior Technical Advisor at Malaria Consortium. She's trained as a pediatrician, and she has more than 20 years of multi-country experience on implementing and capacity building initiatives for infectious diseases, malnutrition, and child health, and has provided technical oversight and management for neglected tropical, oops, the poll just came back on, sorry.
We could send it, we can go ahead.
Sorry. Okay. For neglected tropical programs in sub-Saharan Africa and in Southeast Asia. Sorry about that. Over to you, Prudence.
Thank you, Sandy, very much for that introduction. So today we're going to have session 3, which is going to focus on policy change processes and design. And the objectives of this session is to identify the progress of changes on thinking on radical cure since the previous APMEN working group, which I think was around 2 years ago in Kathmandu. And we want to share and highlight best practices around the themes of evidence to policy and how people access care. And I think that these are very important issues that we need to think about, because however good new tools we have and however clever they are, what we need to do is enable people to use those tools in the field, and that people who are living in remote areas who are most liable to have malaria have access to those tools. And that's why it's very important that WHO guidance is clear and strong, and that national malaria control programs can actually take on those issues and implement them in their countries, in their particular contexts. So I think just to give you some data around Vivax malaria, there are 8.5 million clinical cases of Vivax malaria in the world, and South America is not included in this, but they're one of the main areas as well. And also in Africa, in the Horn of Africa and in Ethiopia, Vivax malaria is a big problem. And in our area, in the Asia Pacific, Vivax is now replacing falciparum as the most common diagnosis of malaria. And it's much more difficult to treat in some ways than PF. And I have to say, in relation to what Dr. Das was saying earlier, that when I was working in South America, doing clinics in a gold mining area in Colombia, the children who had Vivax malaria were actually iller than the children with falciparum malaria, which was quite a change for me to find out. And actually diagnosing Vivax malaria, we know, is more difficult. And there are particular groups like the glucose-6-phosphate deficient, dehydrogenase deficient people who are not able to access a radical cure at all. And we need to find ways of dealing with those people, particularly pregnant women and infants, and the 30% of people who may be glucose-6-phosphatase deficient. So then I'd like to move straight on to this program. So we're going to have a presentation from Dr. Bipin Adhikari, who is going to tell us about the roadmaps that were developed by the National Malaria Control Programs and how those have progressed. So I'd like to turn it over to Dr. Bipin. He is a researcher working at the University of Oxford and currently based in Mahidol, Oxford Tropical Medicine Research Unit in Bangkok, Thailand. He's a medical doctor with a speciality in research skills around tropical infectious diseases and social sciences. He's currently leading an operational research project in Cambodia, exploring the use of the biosensor by village malaria workers among febrile and Vivax patients. So over to you, Dr. Bipin.
Thank you, Dr. Prudence, for my introduction and your opening session. I hope you can see my slide. Okay, yeah, I can see my slide here. So, good morning, good afternoon from Nepal to everyone. So I'll be talking briefly about operational research and then this fantastic online platform for Vivax malaria information, vivaxmalaria.org. Can we move to next slide, please? Yeah, just briefly here, what is operational research? As you might be aware, it's a messy area which comes under the implementation science that studies methods to promote the uptake of research findings into routine healthcare in clinical, organizational, and policy contexts. And operational research is a subset within implementation science, a discipline within implementation science, which is an action research where researchers and the policymakers and health workers work together to identify, to develop solutions, the problems around implementation change, and deal with all the implementation of research findings of program. So it has three main roles and the components. So the number one is operational research helps us to structure an implementation problem. What is it, and how is it originated? Stuff like that. All sorts of characteristics of implementation problem. And the second characteristics of operational research is it allows us to prospectively evaluate an intervention while it is rolling out within the health system in a collaborative way. And third one is it helps us to strategically reconfigure the services, sort of adapt it based on the feedback from that research. So moving on to the next slide, please. Moving on, I would like to share my experience with this fantastic database, vivaxmalaria.org. This has been really fantastic, as I wanted to see the information, the scientific information, evidence around Vivax malaria, and this Vivax information hub is fantastic in finding out Vivax malaria related information. I would like to share how we can use this search box. Next slide, please. So, as you can imagine, why do we need a common platform, a sort of online platform easily accessible to all sort of policymakers, researchers, and stakeholders? There are hundreds of advantages. Briefly, this vivaxmalaria.org as an online platform allows us to identify any remaining research gaps and helps us to save resources for research and avoid duplication. And it will also help us to know what data is already there, and we could use those data to make evidence-informed decisions and for policy making and implementation. And last but not the least, it helps researchers, National Malaria Program, policymakers, and implementation come together, make connections, discuss about or plan research in different forms, and learn from the past research and know about ongoing research in the region. So these are a general overview of how we could utilize vivaxmalaria.org database. Next slide, please. Here you could see breakdown of studies in the database. You could see almost equal proportion of studies that have been deposited into the database. Some are in preparation, and others are ongoing, and others are completed. And you could also see what type of research are deposited in the database, like operational research, studies about safety, efficacy, implementation research, and effectiveness. This will easily help you to navigate through what kind of research you would like to see within the database. Next slide, please. And here's this slide shows breakdown of studies in the database by countries. You might be interested to know which countries where the studies are occurring and what sort of studies as well. So this will help you to first navigate by countries, the studies where the studies are happening, and you could click in there and then look into the studies, what kind of studies are happening. So this is really helpful in this one as well. So next slide, please. You could use a very simple search function within the database. For example, in this search function, we type operational research for the type of research on the top column there, and then we use a keyword G6pd testing, and you could see these 4 results from the database. So the first one is one of the operational research that we are undertaking in Cambodia with CNM. So this is about quantitative G6pd diagnostic, that is Biosensor, use of Biosensor in the hand of BMWs, whether these BMWs can perform well with the Biosensor or not. And you could see another study about compliance and adherence by PATH in India. Similarly, you could see other study occurring in Brazil about rapid test, and then other study in Thailand. So you see, this is a sample of how this search function works within the vivaxmalaria.org. Like you could type whatever research you want to see, and then type keywords, and you could try different options there, and this will allow you to find out the specific type of information or evidence around what you're looking for. Next slide, please. Here, what I would like to show you is you could also identify, as I showed earlier as well, the breakdown of research by countries. Just an example here, really. So if you type Nepal only, so it will help you to find out how studies that are happening in, for example, 3 results that are shown here. So the first one is the study that we carried out, qualitative study. We wanted to understand the perspective from policymakers and stakeholders about radical cure regimen. And the second one is ongoing study. It's a pilot study, I think. So it's conducted by Menzies, and then the third one as well is the Menzies. So you see, you could find out plenty of information just when you type only country's name about vivaxmalaria studies that are completed or ongoing or are in planning stage. Next slide, please. And if you click into one of these studies, then you could see a brief description of what this study is about. And one of the best advantages about this website or this database is, what I liked about this database is, you see these details are extracted out into subheadings on the right-hand side. Under the heading of details, you could see countries where the study was done, like the study involved, and date when the study was conducted, funders, lead group, status, and sample size. This is beautiful. I mean, if you were to go into the published paper, then you would have to navigate through the method section for a while before you could extract this information. Whereas here, you could already identify, some of this important information about this study, and you could decide whether or not to go into the main paper as well. So this is really helpful that I liked about this, online platform. Next slide, please. So and then this is the ongoing study that is now been running 6 months plus. This is about how BMWs can use biosensor machines in Cambodia. And as you can see, again, the details on the right-hand side. So this is an ongoing study. And as you know, operational studies are very messy. It depends upon how we work through, and this is obviously a COVID time, so we are adjusting the timeline. So there needs to be an update, but yeah, this is what it is. Next slide, please. Yeah, so here I was suggesting, and I would like to encourage all of you, researchers, policymakers, stakeholders, please, if you have any information about Vivex Malaria that you would like to share into a common platform for common good, I think this is a good platform to share so that everybody can learn from it. And if you go into the website vivexmalaria.org, into the database, and then you will see this hyperlink, click it, and then you can submit your study. It has a stepwise guideline. You could fill up these forms, very simple forms, really. Title, bid group, website, dates of the study. And this is what I did for my study as well. So yeah, this is very simple. Next slide, please. Yeah, and then if you would like to, provide some generic information related to Vivex Malaria or any other important guidelines or reports or, unpublished work as well, I think there is space for that as well. So you could just type your name, email address, subject, and message, and attach something. And this will help this website to collate all the information about Vivex Malaria and have all this information in one place for all of us to learn from, plan ahead, and save resources. With this, I would like to say thank you to Caroline and Manus for providing some of the figures for this presentation. Thank you. Thank you all.
Thank you very much, Dr. Bipin, for that very interesting presentation. And it's really good to have the evidence around the management of Vivex Malaria all in one place that people can access. And as you say, operational research and implementation research is really, really important. But we need to make sure that that evidence is now translated into policies and practices, because however good the evidence is, we need to use it in a practical way. And we've only got 9 years now left to eliminate malaria in this region. So we really need to move swiftly to make sure this evidence is used properly. So the next part of the session will be led by Dr. Phayol from PATH in Myanmar. He is going to take you through some group work. So hopefully it'll work and how the groups will be done. The groups will be the National Malaria Control Programs, and they will be working to come up with looking at their roadmaps and how they were achieved. And the rest of the participants will take part in a poster session, and Dr. Phil will tell you how those sessions will work. So I'm going to turn you over to Dr. Pho now. He is working as a senior technical officer in infectious diseases. He's an experienced public health profession with a decade of experience in infectious diseases, health system strengthening, monitoring and evaluation at different levels in resource-limited settings in Myanmar. And most recently, he's worked with Save the Children as co-lead and technical consultant, providing technical and strategic leadership in developing key strategies and guidelines for malaria elimination. He has extensive experience translating the guidelines into practice by conducting capacity building activities at all levels for malaria elimination. He has a master's degree in public health, and he was WHO TDR fellow under a TDR postgraduate training scheme with a focus on implementation research. So over to you, Dr. Phil.
Thank you, Dr. Prudent. Good morning and good afternoon and good evening. I'm Phil from BART. I'm here to provide you information on the aims of the group work and poster sessions, their formats and the expected outputs for each session. I hope you have already received a copy of the agenda, so let's get started. So while the group work for NMBs were focused on the Vivex roadmaps that some of you already developed in 2019, and the partners in the poster session will have a chance to learn from early implementation and assess strategies. Next, please. Can you click again? Okay. So we aim to run two parallel sessions. The first one is the group work with NMBs, and the second one is the poster session with partners. So related to NMB group work, in 2019, there was a session with NMBs, which some of you has facilitated to develop a detailed strategic approach for each country towards accelerated implementation of optimal Vivex radical cure. The output from this session was a roadmap or strategic approach to accelerated Vivex radical cure in each respective country. For a country like Sri Lanka, we have focused on understanding the appetite and the potential use of alternative radical cure strategy in the prevention or re-establishment phase. Next, please. Okay, next, please. Yes, this year the purpose is to identify areas where NMBs have questions or need further support to achieve an optimized radical cure that is based on the progress since 2019. So the second objective is to highlight the best practices on early implementation of G6pd analyzers and assessing remote populations. And the third purpose is to enable NMBs and partners to learn from each other's plans and thoughts on Vivex elimination. And also we have a capital of facilitator and admin team to support you in clarifying group work, questioning, and some IT-related technical error. Next, please. Facilitator, could you please switch on your video? Okay, thank you. Let's move on the format of the group work session for NMB. Okay, next, please. Can you click again? Okay, so right now you are here in the main room. The break room controller will create a different break rooms for you, and you will be automatically moved to the break room from which is pre-assigned, and that is based on 2019 groupings and strategically to maximize discussions. Depending on the number of NMBs attending, there will be maximum 8 breakout rooms. Your group will include 2 to 3 members of NMBs, and also you have 25 to 30 minutes for your group work assignment, and you will be automatically returned to the main room after 30 minutes. As I mentioned before, you have one facilitator to support your group work discussion in each room. And also, if you have any questions and comments in your group work discussion, you can make it either using chat function or raising hand to speak. On the other hand, your facilitator will also help you make your question and comments. We will randomly select 1 to 2 groups to present your group work to initiate discussion. So please make sure to leave time for the presentation in your group work. Then let me specifically explore on what you have to do in your group. Next, please. Firstly, you have to identify the presenter within your group in case your group has been selected for presentation to be discussed. I would encourage other group members to be ready for further discussions. So then you need to briefly review the Vivex roadmap developed during APMEN Vivex working group meeting in 2019. So to be more specific, we have developed 4 questions to be discussed within your group members. And also your facilitator will help you probe each question if you need more clarification. So in this group walk, we expect that you would identify the wins and where bottlenecks or queries on progress exists and how APMEN Vivex working group can help address those. Next, please. These are the areas that you are going to discuss with your group members, but you don't need to take a picture or screenshot for it, as your group facilitator will help you explain more details in your breakout room. So let me skip this to be explore more detail. Next, please. We surely expect that you would have clear and detailed responses to these 4 questions we raised, and your facilitator and I will document any other key additional discussion happened when you were answering questions. So these are the main expected outputs for the group board discussion among NMBs. So next, please. Eventually, the system will notice you for the time elapsed when there are 10 minutes, 5 minutes, 2 minutes, and 60 seconds remaining before returning to the main room. So I would encourage you again to ensure preparing for the presentation and discussion in case your group is selected to be presented. So thank you so much. And if you have any question regarding the format, please feel free to reach out to your facilitator in each group. They are ready to help you. And so to my distinguished NMB member, are you ready to go to the breakout room now? Siapo, could you please move NMB groups to breakout rooms with facilitator? See you all in the main room after 30 minutes. My humble request to the partners to await here for a minute to provide you the information of your session. Stefan, if you already finished
yes, I already assigned an FCP manager person to their respective room. Now in the main room, most of them may be from partner institution. So we would like to request, is there any NFCP person stay in the main room? Kindly let us know. So we will move you to the assigned breakout room.
Thank you, Stefan. So Carrie, next, please. Okay. Hello, our respectful partners. Once again, I'd like to thank you all for coming. Now, shall we get down to the poster session? As I said earlier, the purpose of your session is to highlight the best practices on early implementation of G6pd analyzers and assessing removed population with Vivex treatment. Next, please. Next, please. Yes, okay. So like NMB group session, the breakout room controller will create different breakout rooms for you, and you will be automatically moved to the breakout room, which is already pre-assigned. There are 5 groups in which 5 different poster and its owner are in place to explain you. And also you have 6 minutes in each room to hear about the poster, and you can ask any one key question via chat box. And also you have 1 facilitator in your group to support you for any clarification. And the most frequently asked question will be posted to the presenter before we move to the next poster room. In this poster session, you will have a chance to observe all 5 poster, and you will be moved automatically to the next poster room after 6 minutes in each poster. And the whole process will be repeated till all 4 poster badges have attended to all poster. So please make sure to ask questions within 6 minutes if you have any queries about the poster. Next, please. So these are the 5 poster names and the owner of them. You can learn more about them in each poster session. So next, please. But similar to the NMB groups, we also expect that we can learn together from experiences in other countries. Your facilitator and I will document the summary of most asked questions and discussion happening during poster session. Next, please. For your additional information, we have time for discussion after the group walk and poster session, but the plenary will focus on NMB discussion. If we have any unanswered question remaining after the poster session, we will be addressed on day 2 and day 3. So next, please. Thank you so much. And if you have any question regarding the format, please feel free to reach out to your facilitator and in each poster session. Thank you, and see you again after the next 30 minutes. Thank you.